At the end of the day, yes, there's all these other problems, but if you can't house somebody, if you can't meet basic needs, we're going to continue to have problems.
Welcome to Beyond the Threshold, a podcast where we discuss the various ways housing, mental health, and substance use disorders collide. This pod is brought to you by Threshold's Homes and Supports out of Kitchener, Ontario. I'm your host, Ian, and with me today is my co-host, Vanessa.
Hi, everyone. Today we're really excited to have on the show Angela Allt, the Service Resolution Facilitator for Guelph, Wellington, and Waterloo Region. Service Resolution is facilitated by Canadian Mental Health Association and coordinates with community organizations to provide supports for people living with severe mental health and substance use issues. Hi, Angela. Welcome to the show. It's great to have you on.
Thank you for having me.
So we just want to start off by getting to know you. So if you could tell us a little bit about yourself and what inspired you to get into this field.
So those are really good questions. I began my academic career way back when dinosaurs roamed the earth in the 80s. And when I started university, I thought that perhaps I wanted to go into psychology. And first year psych cured me of that. It was one of these very large teaching theaters with 400 or 500 people in it, and it was very dull, dry, and boring. So I ended up actually going into sociology, and liked it so much that I decided I would do a master's degree into it.
Why would you do that to yourself?
It was interesting stuff. It was interesting. So I actually ended up moving up to Guelph from Fredericton, New Brunswick, where I was originally from. And I went to U of G and did a master's degree in sociology. So what do you do with a soc degree? Well, it turns out not a lot. Great learning, but it's not very practical in terms of, employment. So kind of bumped around doing a few different things for a couple of years. And then I got a job as a psychiatric patient rights advisor, working for the Psychiatric Patient Advocate Office. And what that does is when somebody is held in the hospital on a form under the Mental Health Act and told that they can't leave, or they're told that they can't consent to their own treatment or can't manage their own finances, then a rights advisor has to be called in and tell them what their rights are, and give them the option to contest those findings by the doctor if they choose to. And I was originally hired to do the Guelph area, but within a week of starting, I was thrown into doing Kitchener as well. So I was going every day to Grand River Hospital. So I already had this regional focus going on. And then as time went on, I referred to myself as the Southwest Ontario float, because wherever they needed somebody, that's where they'd send me. So got sent over to Sarnia a few times, regularly sent to London, Hamilton, Brantford, you name it.
Well-traveled.
Yeah, I was all over the place. And so, that was the work of going in and seeing people in the hospital, and also working with substitute decision makers, because if they were being put into place to say yay or nay to a community treatment order, then they also had to get rights advice from a community rights advisor. So I did that for almost 10 years. While I'm doing that, I decided that I needed to go back to school yet again. I guess I was a professional student. One of those people.
I feel that.
That's my dream, actually.
That's a nightmare. So I went back and I did my Bachelor of Social Work degree at Renison, and I came out of that and I thought, okay, I'll try and work a couple of years and then go back and get my MSW. And there wasn't a lot of work at that time for people with bachelors. So I thought, all right, throw my hat in the ring now and see if I get in. And I did, and went and got my master's degree, and about a month before I was finished the schoolwork, I got an interview because, of course, by that time we're all out running around trying to find a job. And I had applied for the job of service resolution facilitator. And, was hired for that, and I have been in it ever since. So I guess I had that background in mental health and addictions, and I'd also done some volunteer work with a few agencies as well that brought me in contact with that. So that was kind of the career trajectory.
Mm-hmm. And so, like, what inspired you to get into that work? As some of our listeners may know, as you know, we don't tend to always get into this work for the money.
I guess I've always had an interest in it. If I look back at myself, even when I was a kid, I always had two areas of interest, and it was law and medicine.
Okay.
Right? Those were the things that always intrigued me. And within the field of medicine, like anything to do with mental health in particular, I always found that really, really intriguing. So I think that was one thing. The other thing was that I was always the person that everybody would come to with their problem. And I remember saying at one time, gee, I should be doing something so that I'm getting paid for this. And so to that end, I do private practice work a few evenings a week as well, where it's more that type of hands-on work with individuals and couples as well.
Oh, that's amazing. So in terms of your role in the community, like, can you tell us a little bit about what service resolution is?
So I always say that the quick answer is that I'm the regional fixer. I get called when there is a case where people don't know what to do, or there is a system level problem where people don't know what to do, can't navigate it, have tried to navigate it. And anybody, in theory, can call me in. So agencies such as Thresholds or Canadian Mental Health or the police can call me or housing can call me. But the other piece is that individuals can call me as well, or family members. So it really is an open door for anybody who's experiencing some kind of difficulty. The majority of the work is with the other organizations across the two regions. I probably get about 5 calls a year from family members who have, a loved one who is unwell and they don't feel that they're getting the services or supports that they should have, and probably about 4 individuals a year who say, I'm experiencing mental health problems or addictions problems and I can't get the help I need. So, yeah, that's the small portion of it. The larger portion is the service providers, and that's primarily who I work with.
No, and that's really amazing. I wasn't aware that your services were even open to families and loved ones and to just individuals in communities. That's actually really amazing. In terms of what are the kinds of cases that are presented to you on a regular basis, or some of the more, since they are the more complex ones? Yeah,
so I guess there's a few categories of them. One of the more common ones is that you have somebody who is really unwell in community, and they've been to the hospital several times, and they don't make it past emerge. They're quickly discharged, and there's usually a couple of reasons for that. One might be that they go in and they present to the doctors really well, They pull it together and, no, I'm fine, there's nothing wrong with me. And even if they're questioned about specific things, say perhaps delusions that they might have, they know enough in the moment to say, oh, no, I never said that. No, I don't believe that.
So these would be people like living with schizophrenia or bipolar?
Yeah. And, because they're not giving it up, out they go. The other situation that we have is people who have a mental health problem, or they have a drug use issue in combination with the mental health problem. And unfortunately, we see them discharged from hospital regularly and very quickly. This is an ongoing problem that has been around probably more prevalently since about, I'm going to say, 2015 or so. And the reason that I kind of target that general gear, when I came into this role in 2011, we didn't see quite so much of the drug use issue. Fast forward about 4 years, and that's where we really start to see the rise in the use of crystal meth. Mm-hmm. And where we start to hit problems of people presenting to the emergency department, and they're clearly unwell, but it quite often gets put down to it's drug use, and they will clear, mm-hmm. and they, let the folks come down, and at that point they're, presenting reasonably okay at times, and then they just get discharged.
Yeah. And that actually segues pretty nicely into our next question.
Yeah, so in your view, what are some of the main challenges that you tend to encounter in your work?
Main challenges. So there's a lot of them. And it's always around service provision in one way or another. So when you have somebody who, in particular, we know had a pre-existing mental health issue, and now they're using substances, and it makes sense if you look at it from the point of view of you've got somebody who is, say, hearing voices, and the medications that they're using are not quelling the voices, but you can buy something on the street and that'll make them go away. What are you going to do, right? This seems like a reasonable alternative. Unfortunately, the things that they're buying on the street is causing all kinds of other problems. But again, at the end of the day, we're having trouble getting them into the hospital to relook at medications, because one of the great things about this field that I will highlight is there's new medications coming on stream all the time now, and a lot of them work a lot better, and they have fewer side effects, and they can give people a really great quality of life. But we've got to get them in a place where we can get them on those meds and try them out and convince them that, they need to give it a shot. So, getting people into treatment is one of the big roadblocks. The other roadblock, and this also has to do with treatment, has to do with substance abuse. So, you have somebody who has been using for a long time, and something happens. Maybe they've had a really, really bad overdose where they almost passed away, or something has happened in their family, and they say, no, I want to move on from this. I want to address my addiction. And then when that happens, we probably have a short window of time where they're willing to address it. And then we can't get them into treatment because there are no beds available right away. Quite often, we can't even get them into detox right away because there's no beds. The other thing that happens is, and I know probably a lot of people aren't familiar with this, but there is a screening tool that is widely used to see, gauge somebody's readiness for treatment and what kind of treatment they should be getting. And there's only certain service professionals who can administer that screening tool. And then you have to wait, and sometimes it's a week or more before you can get that done. Well, the opportunity to work with this person who's sitting in front of you right now and says, yes, I want to go to treatment. Okay, a week later, that's gone. That's over with. And now we're back into the cycle again. So that's another recurring theme that we see. And, of course, the other one is that it's no stranger to anybody sitting at this table, and probably to many people listening, is the housing. We do not have enough housing. And we also don't have enough of the right kind of housing, supportive environments that can help people. That's a struggle. And if you can't even give somebody the basics, off of good old Maslow's hierarchy of needs, right? Safety and security, and part of that is having a place to live, a roof over your head. It's hard to do any other meaningful work with them. It's hard to have them accept any support and see those who want to work with them as credible, right? Hi, I'm here to help you. Great, I need housing. Sorry, don't have that, right? And it's like, okay, well, they can't help me with my basic needs, so what good are they to me? These are people who it's very clear to them what they need for the basics. And anybody who is sitting there saying, well, I could do this or I could do that, they're just going to think, well, what good are you to me?
Yeah. It's no good if you're not going to be able to provide me a place to lay my head so you can actually find me to provide those services.
Exactly.
Yeah, or people are staying in hospital until they can find housing, or they're being discharged from hospital where they've stabilized and kind of making improvements, and now they're discharged to the street or the shelter system, where, you kind of fall back into that cycle because it's a means of survival. So.
Or you can't find them to be able to provide medications to them. Yeah. Or other medical supports. Like there's another roadblock that we've had. Somebody has a medical issue. So let's say they need dressing changes or something like that. I don't know if it's still the case, but it wasn't all that long ago that unless we could provide an address, like a physical address, they wouldn't even open a file for them. So then you had people cycling in and out of the hospital just because of the medical issue.
Yeah, and I think do you find that there are certain situations, or I guess the more complex cases, so for instance, you mentioned crystal meth, where community organizations or certain municipalities that you work with that are more resistant when those substance issues are highlighted?
I'd say that's pretty much the same all over. Not a big difference in terms of that. The one thing that I really wish we could do a lot better on as a system is when somebody is going to hospital and there is substance involved and they're in psychosis. Psychosis is psychosis, and you have to treat it. It doesn't matter what the cause is, you have to treat it. And this has been something that has been mentioned over and over again by people who work with it on a regular basis. There's a doctor out of Toronto, and I can't remember his name at the moment, but in the early days, we had him out here doing education events around substance use, and in particular crystal meth, because at first, nobody knew what to do. Nobody knew how to address it. And because he was out of St. Michael's in Toronto, and I mean, they see everything there, right? Yeah. Busy place. He had a lot of expertise around it. And this is, what he would say. It doesn't matter what's causing the psychosis, you need to treat it. And also the fact that we couldn't just kind of discount people who were using, that they needed care as well.
Yeah, now there's also the presence of the xylazine, so it's causing those wounds for individuals. So it's definitely changing the landscape to how we provide care.
Hi folks, Ian here. Just a quick note on xylazine. It's a veterinary drug used to sedate anything from rats to horses. It's present in the unregulated drug supply in Canada and the US. It's typically mixed with opioids like fentanyl, benzos like Adderall, and to a lesser degree stimulants like cocaine for the increased sedative effects. This combo increases the risk of drug poisoning and complicates response due to the added sedation. Xylazine can cause skin ulcers at the injection site and increase infection because it hampers the body's ability to heal sores or wounds. It's still important to keep naloxone handy, however, which you can get from any pharmacy, as it can reverse the effects of opioids, but not the additional effects of xylazine or benzos. If all else fails, call 911. Back to the pod.
Yeah, and I don't know for certain, but I suspect that there's a few people that I'm helping to support in motels, because this is the phone call I get. I've got a guy. He has a really bad wound. it's not healing. We've got to get him into some kind of stable environment, even if it's, a month or two, so this wound can heal. And I'm assuming that that's probably part of it.
Now that you've mentioned the motels, can you tell us a little bit more about your funding related to that?
So Service Resolution has a fund attached to it so that I can cover off some things that other services may not. The majority of that money does go to pay for motels. So that short stay can be anywhere from, a couple of days to a couple of months, depending on the circumstances. It also covers things like specialized therapy for people who can't get it through the regular system and don't have the means to pay for it themselves. So, for example, we have several clients who have DID, dissociative identity disorder, and we don't still yet have a lot of expertise in that area in some of the more publicly accessible clinics. So that requires a specialist. Some people who have trauma who we think could probably benefit from something like EMDR. Okay, so we do a limited number of sessions for that. Other things that I would end up covering.
And sorry, what does EDMR stand for?
EMDR, eye movement desensitization.
I think processing?
Processing.
No. Reprocessing, perhaps? I can't
yeah,
remember
something
fully.
like that. Yeah. I don't practice it, so I'm not up on all the acronyms. Often have to pay for some assessments to see if people actually qualify for Developmental Services Ontario. Covering medications for somebody while they get their other coverage in place. Yeah, it's just some odds and sods that people can't get covered anywhere else.
So it sounds like there are quite a bit of challenges and some barriers with regards to the services you provide or the services that community partners provide in general when it comes to whether it's severe mental health on its own or severe mental health mixed with substance use disorders. What, in your thoughts, is maybe a few ways that we can move forward to address those challenges?
Good question. I think that we've all got to really put a push on at any level of government that we can to fund housing. At the end of the day, yes, there's all these other problems, but if you can't house somebody, if you can't meet basic needs, we're going to continue to have problems. So I just really encourage agencies to push that agenda, and for private citizens as well. And for anybody that says, well, this isn't my problem, I would beg to differ. This is your problem, because if you're concerned about where your tax dollars are going, let's try and get them going somewhere that will lessen the need for some other things. Police, ambulance, costs to the hospitals, costs in the justice system. And yes, these come from different levels of government, obviously. But at the end of the day, there's the big pots, right?
They're all drawn from the same wells.
Yeah, they're all drawn from the same well. They're all drawn from our pocket, one way or another. Mm-hmm. So let's push to have the money going to places where it's going to do some good and make improvements in those areas as well. I think if you talk to anybody from the hospitals about what the effects of mental health and addictions has been on their numbers, even in their emergency rooms, in their inpatient programs, in their outpatient program, they're going to tell you it's shot up over the years. To the point we don't have enough resources, they don't have enough resources, right? So yes, I fully support lots of other programs that are going on and that we need to fund them. But I think that's the big one we need to look at right now is please let's house people appropriately. So that may mean supportive housing. And I think we also need to have a really, really frank conversation about what do we do for the people who are the most vulnerable and who are the most unwell? And this is where I would say this is an unpopular topic, but I will dare to bring it up. So back in the 60s, the movement started to deinstitutionalize people and to close the psychiatric hospitals. And there was a feeling among the consumer movement that everybody could be successfully supported in the community. And I know that that was really well-intentioned, but it also, in my opinion, wasn't realistic. I think the majority of people with appropriate supports can be supported in the community, the majority. But there is a small handful of people who are chronically too unwell to be supported in community. And we need a different model for them. And I envision something that would look maybe more like a long-term care home. And maybe that's what we'd label it, long-term care for mental health and addiction. And just like a long-term care home, you have units that people are free to come and go on, and you have some units that are locked. Because, like I say, we have some people who, unfortunately, they're just so unwell that it's not really safe for them, and sometimes safe for others, for them to be out in community. It's not their fault. It's no one's fault. They're just not so unwell. And I think it's incumbent upon us as a society to ensure their safety and ensure the safety of others in those cases.
Be curious to hear your thoughts on, I know some Nordic countries have dementia communities. There has been some pushes for mental health communities of a similar note for individuals that you're describing. What do you think that would work here, or what are your thoughts on those?
I'm fairly familiar with the dementia communities because that tends to get some airplay, right? On the nightly news when they have a good model that they want to highlight. And I think that they're really on to something like that. Like I remember one of them's called Butterfly Community, and there's somewhere down in the Toronto area where they've actually got that up and going within one of the homes.
That is right.
Yeah. So I think that you can probably take any model that is reasonably sound and try it. I'm all for giving it a shot because what we're doing isn't working. And I'm really getting frustrated hearing about clients who they were not well to begin with and trying to support them in community, and they have continued to decompensate over the years. And I see this relentless cycle of them in and out of the hospital and or in and out of the hospital and in and out of jails. And then we finally get to the point where either I hear that they have passed away due to drug poisoning, or that they have either significantly harmed somebody or they've killed somebody, and now they're in a federal institution. And it's like, why do we have to wait for this to happen? And we can see the trajectory, right? We can see it. And, it's always the same thing. Why do we have to wait for something horrible to happen, right? They deserve better. And we need to have the right type of facility. So I'm not really familiar with these mental health communities. I'd love to learn more about them. But if that's something that we could bring here, hey, by all means.
Definitely some preventative work needed, given that I find that the system right now is just a lot of reactive and putting out fires to try and help people the best that we can. So kind of moving back towards the topic of substance use, namely crystal meth, fentanyl, things of that nature. Do you sit on any drug strategy committees?
Yeah, I sit on one drug strategy committee. Guelph Wellington Drug Strategy Committee, and I will say that they have done some fantastic work over the past 12 years or so, and really have pushed the envelope at times to get funding for programs that, weren't in wide use. And I think they were one of the first safe consumption sites in the province, if I'm not mistaken. So really great work going on over there. And the committee, we recommend work plans and things like that, but it really is, the person who's chairing it or the person who manages it, who really gets the work done, with some input from a lot of other community agencies who, of course, inform what they're seeing out in the community.
Absolutely. Do you sit on any other committees?
Well, I sit on the Extraordinary Needs Committee, which is hosted here by Thresholds, but is part of the wider community system. And that program, again, goes back to 2011, because I think I was in this role maybe 2 months. And all of a sudden, a bunch of us were called to a meeting that there was this money available for a pilot project, and how could we use it? And the focus at that time was to get people who were what they called alternative level of care. So, blocking a bed in the hospital. Was there a way we could use these funds to get people out, and particularly people with mental health and addictions? And so there was a hurried round of meetings where a business case was developed and submitted at that time to the LIN about how it could be used. And it was approved, and it came base funding after a year. And then we went back with another proposal a few years later, and that was to have housing. And that was so that we could take some of these folks who have higher level of needs and who need a supervised setting and have a place for them to live where they would have the supports that they need. Mm-hmm. And so we got that at the time, and there was 2 sites, one in Guelph and one over here in Kitchener, and that has continued as well to this day. And the other part of the program, where people put in requests for funding so that we can stabilize people in the community after they come out, that's also continued and has served a lot of people over the years. So I sit on that committee with people from a number of agencies around the region, and our role is just to kind of consider the requests that come in, and also if any adjustments need to be made to criteria or things of that nature.
Okay. Thank you for sharing that. We're getting close to our end, so just a couple things. So what would be your message to our listeners or our community at large that you think they need to hear in order to foster change?
I think the message is to look at the population that I'm working with, and as I said, mental health addictions, but they may also have a brain injury. They may also have a developmental delay, and in combination with any of those things, and ask themselves, if this was your family member, if this was a friend, would you not want them to have the services and supports that they need? Would you not want them to have a decent place to live? Would you not want them to have community that supports them? And when given the opportunity, advocate for those things that will support people. And don't be the NIMBY. Don't be the NIMBY. Don't be the person that says, not in my backyard. Be the person that says, yes, in my backyard, and how can I help?
Great. That's an excellent note to end on. Is there anything that that you would like to promote or talk about that we haven't touched on?
No, I don't think so. I think we've had a pretty kind of wide-ranging conversation on what the needs are, and I know that there's many people that are fully aware what they are, but we just have to keep working and try not to get discouraged, because I think that's a big thing right now, that people that work in the sector, they're getting discouraged at times, and it's easy to see why. But, you know, as I always say, I just get up each morning and I go to work and I do the best that I can and, you know, hope for a win that day.
Well, don't we all? And I really appreciate it. That's a good sentiment as well. And I think our listeners, and especially when anyone involved in our field, can definitely relate to that. So thank you very much for coming on the podcast, Angela. It's been a blast getting to know you a little better and about the great work that's being done. I really appreciate you taking the time to share your perspective on how to address housing, mental health, and substance use. Finally, a big thanks to our listeners for joining us for another awesome edition of Beyond the Threshold, and we'll see you all later. If you enjoyed this episode of Beyond the Threshold, please like and subscribe and leave a rating and review. For more Beyond the Threshold and information from our sponsor, Threshold Homes and Supports, you can find us on Spotify, Google Podcasts, and Apple Podcasts. You can also check us out at thresholdsupports.ca, or you can follow us on Instagram at Threshold Supports, on X at Welcome to THS, as well as Facebook. Thanks for listening.